Now I'd like to formally introduce Dr. Emily Reeve, who's a pharmacist and senior research fellow in the Quality Use of Medicines and Pharmacy Research Center, UNISA Clinic in Health Sciences at the University of South Australia. Dr. Reeve is currently supported by an Australian National Health and Medical Research Council investigator grant. Her research focuses on optimizing medication use through deprescribing in older adults and people living with dementia. She has a particular interest in consumer attitudes towards deprescribing and the development of deprescribing guidelines. I had the pleasure of speaking with her on Zoom the other day, talking about planning for the webinar, and she's just a lovely person, and I'm sure you'll get that sense when you hear her speak today. So I will disappear for a while and pass it over to you, Emily.
Okay, thank you very much. I'm very excited to be presenting today. Thank you very much to Therapeutic Initiatives for the invitation. I spent 3 years living in Canada, so I feel like I'm a little bit part Canadian, and so was very aware of Therapeutics Initiatives and all the great work that they do. So I'll just get my screen sharing. Okay. That should be good. Obviously, Aaron, somebody jump in if you're not seeing the right thing. So as was mentioned, I'm currently supported by the National Health and Medical Research Council, which is essentially our Australian government. I have received grants and honorarium in the past 3 years from a number of different organisations. They're essentially all university and government organisations, but I have highlighted that we did receive the Cochrane Review support program for this review that I'm presenting on today. The other thing I would like to start with is that I'm in Australia. I know everyone's in different places in the world right now, but I'd like to begin by acknowledging the traditional owners of the land of which I'm presenting from today, and would also like to pay my respects to elders past and present. I'm in Adelaide, which is in South Australia, and this is the lands of the Kaurna people. A couple of learning objectives, and I've highlighted a few kind of key points. So it is going to be the potential benefits and harms, really going to think about the limitations of the evidence, but we'll discuss the factors to consider for deprescribing antihypertensives in older adults. So to start with antihypertensives, so hypertension or high blood pressure is prevalent, particularly common in older adults. And the reason we care about it is that it's an important and modifiable risk factor for cardiovascular disease. And cardiovascular disease can be quite burdensome. So for example, if somebody's had a myocardial infarction, it can have direct effects on their quality of life, as well as future risk of mortality as well. So use of antihypertensives is very common in older adults. There are multiple different classes of antihypertensive medications available. These different classes do have additional benefits or harms in different conditions and risk factors specifically. I'm not going to be going into any of that detail, but just thought I'd put it there because there are quite a few medications in this class. Okay, so if we think about appropriate prescribing for an individual and about whether antihypertensive would be used, we're probably going to consider what clinical guidelines are available, but there are some limitations to these. So the recommendations are primarily based on efficacy in population level studies. And particularly when we're thinking about older adults, the original studies which are used to inform the guidelines may not actually have a representative population. So as well as thinking about guidelines, we're also going to think about how do we individualize this for the person that's in front of us. And that includes things like their values and their preferences, as well as considering what their individual likelihood of benefit or risk of harm are. And with antihypertensives particularly, there are other factors that we might be thinking about that can affect cardiovascular disease risk. So things like diet and lifestyle, and there are actually calculators and cutoffs that are available to guide treatment. And with all of this, it's important to stay focused on our goal, which is to maximize benefit and minimize harm, which includes overall drug burden, and really optimize quality of life, making sure that the treatment aligns with the patient's preferences and values. So all of these things still exist when we're considering deprescribing, but there's some added complexity. So for starters, clinical guidelines don't include or generally don't include deprescribing recommendations. This is absolutely a field where this is changing. So it's going to be really excited to see over the next few years. When we're thinking about individualized treatment, it's important to remember that there have been changes since that medication was started and think about how have those changes affected the likely benefits and harms in the individual. The changes might also influence their ability to adhere to different recommendations around diet and lifestyle. And we really don't know how cardiovascular disease risk calculus should be applied in this kind of setting. And as well as the individual changes, they will have changing goals of care as well. So thinking about antihypertensives in older adults, when we think about the potential benefits in this population specifically, older adults actually have a greater cardiovascular risk and blood pressure can increase with age. So it's actually potential that older adults have more potential for benefit from these medications. But on the other side of the scales is the potential increase in harms through increase in adverse drug reactions, as well as polypharmacy. There are some people in which blood pressure decreases with age, and there's some emerging evidence that a higher blood pressure might be protective of certain things in frail older adults. So overall, there really is a lack of evidence on both what the expected benefits and the expected harms are, particularly in the oldest olds. So people not just in their 60s and 70s, but 80s and 90s, and those with multimorbidity, polypharmacy, and frailty, which we know are very common in our older adult population. So specifically thinking about the risks of antihypertensives in older adults, we do see an overall increased risk of harm. And there's a couple of reasons for this. So the first is that their body actually changes with aging, as well as with things like frailty and other comorbidity. So that includes changes in pharmacokinetics, so how the body is absorbed, distributed around the body, the metabolism, as well as the excretion, as well as the pharmacodynamics. So we do know that there are some changes to the renin-angiotensin-aldosterone system, as well as a decrease in beta receptor activity, and these things can influence the benefits and harms of use of these medications. As I mentioned, older adults also generally are on more medications and have more medical conditions, which can lead to a risk of drug-drug and drug disease interactions. And as I mentioned, changes in goals of care, particularly of relevant for these medications is the change in the goal of prolonging life, potentially at some point in time, that being changed to a goal which is more about maintaining or maintaining function, as well as optimizing quality of life. There are some specific drug reactions that we see with the different drugs, but there's a few other things that are of concern in older adults. So these are things like orthostatic hypotension, falls, and as I mentioned before, that the higher blood pressure is thought that it might be protective of cognition, but this is still something that more research is needed in. And then the general burden of polypharmacy and the associated risks of multiple medication use. So all of this led to myself and the team that did this Cochrane review to investigate whether withdrawal of antihypertensives is feasible and to evaluate the effects of withdrawal of antihypertensives on mortality, cardiovascular outcomes, hypertension, as well as quality of life in older people. The team of authors that did this review, we are multidisciplinary, so we've got pharmacists and a number of different medical professionals, as well as having methodologists. But so we were really driven, we want to be able to do this review to be able to inform deprescribing in clinical practice. I'm going to start with a bit of a spoiler, and hopefully you'll stay for the rest of my presentation, but we weren't really able to answer this question in the way that we were hoping, to have something that was really transferable to practice. But we did learn a lot by doing the process and some really key outcomes in terms of implications for future research. So we thought we had a pretty clear question. We wanted to know about deprescribing of antihypertensives in older adults. And so we thought that developing the inclusion criteria would be quite straightforward. We were including randomized controlled trials. We are focusing on older adults. For this review, we did end up using a cutoff of 50 years and older. This was because we knew a few of the studies we might be interested in were a bit older, and we also didn't want to inadvertently exclude studies from developing countries where the life expectancy is lower, and so the consideration of what's older adults might be younger. We were looking for the medication used for hypertension or primary prevention, which is really important for me to emphasize in terms of discussing these results, but we're including any setting and any antihypertensive medication. Then we hit actually looking at the studies to include, and we ran into this issue with, well, what does this age cutoff mean? And we realized that some of the studies, partly based on the age of the studies we found, maybe actually didn't have a clear or didn't say that the cutoff was 50 years or older, but most of the participants or all of the participants were. So we actually had to go back and kind of refine what we considered in terms of the older adult inclusion criteria. The second one that was a bit of a sticking point was that, as I said, we were looking for when the medication was used for hypertension or primary prevention. Some of the studies we found indicated that this was the reason for the drug use, but then in the results, reported some participants having cardiovascular disease. So because we had ended up with quite strict inclusion criteria, but we didn't want to exclude everything. So we ended up with a cutoff that as long as less than 20% had cardiovascular disease. That cutoff was informed by one of my co-authors. It really was a pragmatic decision though. So after going over those inclusion criteria, we had to ask ourselves, well, what's the intervention? What is a deprescribing study? And myself and a few others on the team had been involved in some systematic reviews about deprescribing in the past. And we really, in doing that, realized that there's kind of almost two main different types of studies, which are both called deprescribing studies or deprescribing interventions. And in the past, including in reviews that I've done, we often group the studies together. But as I'll explain in a moment, it was important for us to only include one of these types of studies. So this is the first one. And essentially, you've got an intervention group over on the left-hand side. And then the intervention is that all participants have the medication ceased, which may be blinded or not, as indicated by the people being grey, that they're off the medication. And then at the point of follow-up, they're often measuring, or some participants will need to restart the medication or withdraw from the study, depending on the different criteria. So if we contrast this with the other type of study that we see, so we again start with an intervention group, but instead of everybody in the intervention group having the medication stopped, instead it's that an intervention, or what's often called an implementation strategy in implementation science lingo, is then applied to that group as a whole, or each person gets it. For example, a medication review, perhaps done by a pharmacist, which then makes recommendations to the prescriber, or by a patient-directed intervention, like a patient empowerment brochure. And then this intervention then has an effect, and some proportion of that population will stop the medication. And then in the follow-up period, again, we have some participants that need to start. But there were two key aims of our study. One is the feasibility and the other is the outcomes. In terms of these things, particularly the feasibility, mean two different things in these two different studies. So in this first study type, the feasibility often refers to how many people are able to remain off the medication. Whereas in this second study type, the feasibility often relates to the intervention or implementation strategy itself. So was that applied, and how many people were able to stop based on the intervention? So if we were to talk about feasibility as a whole of these two different types of studies, they would actually kind of mean two different things. And then also if we're looking at outcomes, if we just even compare these two follow-up groups, and I have to say that a lot of deprescribing studies of this second type aren't actually even this successful. This is just an example that I pulled up. You might only end up with a small proportion of people who actually remain off it at follow-up. So comparing clinical outcomes in the group in this first type of study versus second type of study are going to be very different. They're not really equivalent. For this study, We did decide that we were focused on this first type because we really wanted it to be about the drug itself and not, I guess, the process of deprescribing, which is still incredibly important, but we needed to have a focus for this. So this essentially led to our intervention type being that it had to be withdrawal of all antihypertensive. We did allow whether the cessation was abrupt versus tapered. The control was obviously no withdrawal. And we did include studies that had any additional intervention, so dietary advice or exercise, or if other antihypertensives were continued. Again, this was because we really wanted to know what was the effect of discontinuing the medication with removing all other potential things that could confound between the groups. But it did mean that we ended up with quite a strict criteria, inclusion criteria. This is a really kind of high level description of part of the methods. Anybody who's done a Cochrane review know that it is quite a robust process, which actually also means that it takes a lot of work. I'll bring up my team members at the end, but it absolutely was a big undertaking. And the other thing that is important with Cochrane is that we actually submit to Cochrane that we want to do a specific review, and then they review our protocol, and that gets published. So just in brief, we did search a number of different databases as well as trial registries. We didn't limit to any language or publication year. And we did have a Cochrane information specialist that helped with all of this, who was fantastic and a huge help to our review. For the screening and selection, we did have dual independent screening of titles and abstracts, as well as the screening of the full text. And we use Covidence, which is an online tool, which really helps facilitate both the screening as well as we used it for the data extraction and quality assessment, which again was done dual independently. And we had a third person we consulted for discrepancies. And we also, in terms of the quality assessment, we used the Cochrane risk of bias tool. So we ended up with just over 3,600 records after we'd removed the duplicates. Of these, only 39 studies made it through to the full text assessment. And of that, only 6 studies were included in our qualitative, which was essentially our narrative summary, as well as our quantitative meta-analysis synthesis. This was a lot fewer studies than we were expecting to get, given how much antihypertensives it had used and the fact that we were including all antihypertensives. But on the flip side, it also wasn't surprising, as many of us had been researching in this field of deprescribing specifically. There is still a relative lack of studies in this field in general. So we ended up with the 6 parallel group randomized controlled trials. The follow-up period between the studies varied quite a lot, from as short as 4 weeks to just over a year. Same thing with the sample size. There was huge variations in the size of the studies. 4 of the studies were conducted just in primary care in general, although 2 of them were in geriatric specific institutions or a geriatric ward. The mean age did range from that lower end of 57.5 up to 82, which was maybe actually almost that was what we were picturing when we were thinking about older adults. And obviously those higher age were from the geriatric specific studies. The population for, and the target medication really did vary again by study. Most of them had some criteria that if they'd been on the medication and their BP had been controlled for anywhere between 1 and 12 months, that was what made them eligible, as well as blood pressure cutoffs according to their, how they defined it for their study. One study did include a slightly different population, which was people with mild cognitive impairment. The majority of the studies looked at diuretics, although 2 of them looked at any antihypertensives, although from memory, most of these also, the majority were diuretics. 3 of them did report that the drug was slowly tapered or had some kind of tapering regimen prior to discontinuation, but 3 actually didn't provide any information about whether it was abrupt or tapered. In terms of our risk of bias assessment, as you'll see from this slide, the main areas where we were concerned about a high risk of bias was in the blinding, both of the participants and personnel, as well as the way the outcomes were assessed. There was some incomplete outcome data or attrition bias in a number of the studies, as well as some concern about selective reporting or reporting bias in about half the studies. So we get to our primary, or one of our three primary outcomes, which is mortality. At the top of this, we've got our summary table, and then below is our forest plot. So we're only able to include only 4 of the studies actually reported mortality. Again, those did have a range of follow-up from 12 weeks to 12 months. And we found that the odds ratio was 2.08 in favor of continuation, but there was a wide confidence interval that also included the null result, which is essentially that the 2 groups were no different. And for a couple of reasons, we assess our certainty in relation to the evidence as low. And I'll come back to talk to about the certainty in a little bit. The next primary outcome we're particularly interested in was MI, or myocardial infarctions, obviously one of the key cardiovascular disease events that antihypertensives are often prescribed to prevent. Only 2 of our studies actually reported this. And again, one was with a short follow-up, about 16 weeks. The other one was a 12-month follow-up. And again, the odds ratio was in favor of continuation, but as you can see, particularly on this forest plot, really wide confidence intervals. And we actually rated this one, the certainty of this one, as very low. The next primary outcome that we were particularly interested in, and this is maybe more from a deprescribing perspective that is maybe not as, I guess, as much of a priority in some other systematic reviews, but we're really interested in adverse drug reactions as well as adverse drug withdrawal events. Unfortunately, we weren't able to do a meta-analysis. There was huge variation in terms of how this outcome was reported. We saw some possible benefit through reversal of ADR, so lack of ADRs in the intervention versus the control group. So there were some that reported a reversal of a postural drop, maybe some improvements in renal function, cholesterol, or other electrolytes. The possible harm or adverse drug withdrawal event that we saw, this is excluding the obviously the other outcomes that we're reporting on, was that one study saw an increase in ankle edema, but then a different study reported that it got better. And essentially no studies actually used this term or described it in any way, them as withdrawal reactions, and overall the certainty of evidence is very low. This is, again, was maybe not surprising to us. This is a common limitation amongst, well, a lot of drug studies, but particularly in deprescribing studies. There really is a call at the moment to make sure that capturing of adverse drug reactions as well as any possible adverse drug withdrawal events, because really we don't know from these studies. There could have been a lot more that did have a withdrawal event, but because it wasn't captured in a specific way, they weren't able to report on it. Then we get to our secondary outcomes, and obviously blood pressure was one of the ones we were looking at. So we did see both in the systolic as well as diastolic blood pressure that there was an increase in the blood pressure with the discontinuation group versus the continuation. And this included 5 of our randomized controlled trials. The main thing we encountered with this, though, was moderate to substantial heterogeneity. So there was huge differences between the findings of the different studies, which we measured, was able to be measured with the meta-analyses. We had pre-specified that that we were going to do subgroups, both by duration of follow-up. As I mentioned, some were as short as 4 weeks, or in this case, it was 12 weeks. Some were continued to 12 months follow-up. And so we did separate and do sub-analyses by less than versus more than 12 months of follow-up. And then we also did a sub-analysis based on which antihypertensive they were on, which, because of what we found, we did diuretics versus, any drug class. For the systolic blood pressure, none of these subgroups explained the heterogeneity that we'd seen. In the diastolic blood pressure, follow-up length maybe explained heterogeneity, and we saw a difference, but it didn't completely explain it. to go over a few of our other secondary outcomes slightly quicker. But as you'll see, for most of these, there were very few studies. In fact, for falls, we're really surprised. None of the studies that we identified captured falls or change in falls or rate of falls or anything like that. Hospitalization and quality of life, only a single study each. Stroke, there was a few, 3 studies that we could include. Overall for these, we had to rate them as low certainty of evidence. And then the final outcome that I'll mention, and this is really related to the feasibility question that I mentioned right at the start with the 2 different study types. So we were interested in how many people had to restart the medication. So all of the studies had some description of that, but really only 4 of them reported actual results around that. These studies all had some criteria which was applied to both groups. That would mean that either the medication was restarted or they were withdrawn from the study. And this was the same that was done for the continuation as well as the discontinuation group. And I do have a slide later about what those criteria were in relation to blood pressure. We were only able to include 3 of them in a meta-analysis. The comment here I've got about Langford. So this was one study which had a bunch of different groups, and we were able to include some of the groups that didn't have any external, confounding factor like a dietary or something like that. But unfortunately, that one didn't really report the results in a way that we could find out what the continuation success rate would have been. And again, we see these were mostly actually with the longer follow-up, so 6 months to the just over a year. We did find an odds ratio of 3.2, so essentially it was more likely in the discontinuation group that they would need to restart or withdraw from the study. But again, we saw substantial heterogeneity in this, and you can even see just from looking this that one of the studies actually had a higher rate of meeting that criteria in the continuation group and a lower rate in the discontinuation group. So overall, we also rated this as low certainty due to the heterogeneity as well as indirectness in the assessment. So talking for a minute about that certainty and how we got to that. So this is informed by grade, which is also what is part of doing a Cochrane review. And for randomized controlled trials, which is what we were including, there are a number of factors that can lower the certainty. And depending on each of the outcomes, so the certainty is rated per outcome, which is what I was saying as I was doing this, whether or not you have concerns about each of these things. You can actually downgrade. So it starts with high, moderate, and then there's low and very low. As you saw, we downgraded all of ours to low or very low. The main reasons for downgrading across the different outcomes from our studies, there was some risk of bias. So that the risk of bias table that I showed before, that essentially informed one of these criteria. As I mentioned, attrition bias. There were in a few of the studies, there were quite high as well as quite uneven dropouts between the group, as well as the issues in terms of lack of blinding and reporting bias that I mentioned. The next thing that we did see, as I mentioned, in relation to a number of our outcomes was inconsistency or heterogeneity, which for our meta-analyses we were able to actually calculate, although we can still do by looking at the numbers. The next one was indirectness. This was related to the age of studies, populations. I'm going to talk a bit more about this specifically a bit later. And then imprecision. So because we're looking at outcomes like death and myocardial infarction, they occurred at a very low rate. And because particularly in the smaller sample size studies, it means that the total number of events is low. So if you've got 1 event in one group and 2 events in another group, it's a lot harder to kind of, know that that's, have confidence in that finding. And as I mentioned, our 95% confidence interval for most of the outcomes or many of our outcomes included both the null effect and what we would consider an appreciable benefit or harm. So we came to some conclusions for our Cochrane review. And essentially for the outcomes of all-cause mortality and myocardial infarction, which were 2 of our primary outcomes, we had to conclude that there was no evidence of an effect of discontinuing versus continuing them when used for hypertension or primary prevention of cardiovascular disease in older adults. What we're essentially saying with this sentence is that we didn't have evidence to enable us to actually refute the null hypothesis. So really this sentence could read, there's no evidence of an effect, but no evidence that there's not an effect because of those really wide confidence intervals. And obviously this sentence about no evidence of effect is very quickly followed by the note about the certainty, and really that these limitations mean that we cannot make any firm conclusions about the effect of deprescribing antihypertensives on these outcomes. So essentially, as I mentioned at the start, we had hoped that there was some quite clear clinical, potentially clinical implications that with further work could, inform recommendations, but we really couldn't do that from this study. But we learned a lot in the process, which has implications for systematic reviews as well as deprescribing research, particularly in this field of antihypertensives. Populations with we do think that there should be more research in populations with greatest uncertainty of benefit risk ratio for use of antihypertensive medications, which I'll talk about on the next slide. And as you kind of saw, there was only one study that measured any quality of life. None of them looked at falls. The adverse drug events, withdrawal events were really badly reported. So as much as things like mortality and myocardial infarction are important outcomes, there is, recognition that we need to be measuring outcomes that are clinically important to the individual as well. So kind of often what are called patient important outcomes. So as well as generally saying that we don't have certainty in our results, there are a number of things that limit essentially the completeness and applicability of our review. So what are the main limitations? We actually, 5 of our 6 studies were more than 20 years old. I think the very first one was in 86, which means there's probably some people on this webinar who were not born when this study was done. Obviously, this is important for something like hypertension and prevention of cardiovascular disease, because standards of how we treat those things have changed hugely in those years, as well as massive changes in dietary and exercise and things like that impact the populations that were in those studies versus what that population would look like now, as well as all that supportive treatment. While all of the studies did select a population where, I guess they were saying, this is a group of people that may be able to deprescribe or stop their medication because they were taking people who had been stable or controlled blood pressure. But there are actually lots of clinical scenarios that I think are encountered quite regularly in practice that weren't really examined in this. So things like, in somebody that's got a history of falls, in somebody that has a postural drop, or specifically targeting people who have that much lower blood pressure. As I mentioned, this limited evidence and studies on some of these really clinically significant outcomes. The majority of studies looked at diuretics, which really means we're even less certain, we know even less about, beta blockers and ACE inhibitors and all the other antihypertensives that I used. We did have, as I mentioned before, we chose the cutoff as 50 as our older adult criteria. But really, I guess what that meant for today is that we probably wouldn't consider somebody who was 50 to be an older adult. And this was also reflected in the chance that the people in these studies probably didn't have polypharmacy or multimorbidity and weren't frail. We can't tell you how many people did because there was none of the studies reported frailty. Frailty is probably not surprising because it is a much newer concept. And of course, most of our studies were 20 years old. But I think measurement of frailty is already something we're seeing to be a lot more common in studies that are looking at older adults, because, a lot of those changes that I mentioned earlier in terms of pharmacokinetics and pharmacodynamics, we have some knowledge about changes with chronological age, but we also know that chronological age isn't always a good marker of the susceptibility of somebody to risk versus benefit. So frailty is kind of that thing that has come about to fill that gap. Also, none of the studies reported on if the patients were on any other medications, non-cardiovascular medications, or any other comorbidity, which was a little bit of a surprise to us, that there just wasn't actually reporting of those things. So obviously it's important to view our Cochrane review within the context of a couple of other reviews that have been done in this field. Some systematic, some not. Some of them didn't just focus on older adults or didn't restrict to randomized controlled trials like we did, or looked at special populations. Overall, their findings, essentially mirrored ours, which is that it's probably feasible for some proportion of older adults to discontinue, but no clear evidence on who that is. And yeah, massive uncertainty in the benefits and harms. So for example, previous reviews have found that, potentially between 20 to 80% of their participants were able to remain off or stop antihypertensives. And in fact, I'm pretty sure this review included both the different study types that I mentioned at the start. So this, 20 to 80% actually includes people that might not have actually stopped it in the first place. It's how many out of a population ended up, on it versus off the medication at the end of the follow-up period. And essentially all the studies report that the reason for restarting the medication is due to increased blood pressure. Again, other reviews weren't able to identify a description of withdrawal symptoms. And generally they did find, like we did, an increase in blood pressure in the discontinuation group. There were a few studies that so one review that focused specifically on the impact of cognition. As I mentioned earlier, there's some evidence that a high blood pressure in people who are older and suffering from frailty may actually be protective in terms of cognition. And then the other review focused on actually preventing falls. So this was in a high fall risk population. Both of those reviews kind of concluded that there may be an effect, but it may be a positive effect of deprescribing or discontinuation in these specific high risk groups. But they just, again, way too much uncertainty to really be able to make strong conclusions about this. So thinking about blood pressure and blood pressure cutoffs, these are the studies that we included. And you can see here, there's a huge range from, like having participants eligible if their blood pressure was less than 140, all the way up to less than 180 in the 1997 study. Oh, sorry, the earliest was 82. So yes, maybe a few people watching who weren't born when these studies were done. And then most of them had a similar blood pressure criteria for restarting, though some of them didn't. Some of them actually had a higher, like Myers, it was more than 180 to restart. There is still a lot of debate, and I will absolutely declare I am not an expert in this field in terms of specifically around blood pressure cutoffs. Current guidelines still vary in their recommendations, with some, internationally, somewhere it is quite stringent, so that the target is aiming for less than 120, to somewhere it's less so. Generally, all of the guidelines do recommend being less stringent for older versus younger adults, and even more so in people where there is concern about frailty or limited life expectancy or other pragmatic conditions. Recently, I actually just saw this the other day. I think it came out a bit earlier this year. There has been a Cochrane review on blood pressure targets in adults with hypertension. Maybe this is a topic that needs to be discussed at a later one. I won't go into detail because I probably won't do the review quite justice. But they weren't really, again, able to find compelling evidence in terms of going for a lower versus a higher target, but they do highlight a number of limitations of their review as well. And then the last thing I'm just going to mention, just because I think this study is really great. Many of you might have seen this. I'm not sure if some of the authors might be listening to this webinar as well. The reason I've specifically mentioned it, partly because I think it's a really great study, the other reason is that it actually wouldn't have been included in our systematic review. So it wasn't published until after we'd done our final search, but even if it had, we wouldn't have included it. The main reason for this is that they included people who are on two or more antihypertensives, and they stopped one of them. And really that probably better mimics clinical practice than the studies that we ended up with, or our look at, people having to stop all the antihypertensives that they were on. The other thing I think is really interesting about this, again, I am not an expert in the statistics, but there's been a lot of discussion about what analyses are we using, is it appropriate in terms of the meta-analysis methods that we use for treatment studies versus deprescribing studies. And this study actually went with a non-inferiority trial, and so far they've only reported their outcomes at 12 weeks, but I'm pretty sure I was told via Twitter that they are doing follow-up, which is really exciting. So I'm excited to see the results of that study. There remains a lot of questions for me as somebody who is interested in deprescribing research, and particularly with the antihypertensives. There is almost this interesting kind of back and forth between, is it deprescribing in terms of, or complete withdrawal of drugs, or should we be phrasing the conversation more around de-intensification? Something similar to with people with type 2 diabetes, there's a recognition and some quite good data now in terms of older adults to again be less stringent in terms of the HbA1c or the blood sugar that we're aiming for. And then, of course, there's questions around what is the trigger for deprescribing. Should it be a blood pressure cutoff? Should it be other things? Do we need to redo cardiovascular risk calculators to say when somebody should or shouldn't deprescribe? And then particularly with antihypertensives and similar with other preventative medications, how is considering deprescribing about them different in the context of limited life expectancy? We're quite comfortable with talking about time to benefit in terms of, would you start this medication in somebody with a limited life expectancy? But I guess there's still conversation going on. Well, can we just flip that and say, well, time to benefit versus time for the benefit to be gone? There's actually, one drug that actually can have an effect for up to 5 years after you've stopped it. That's actually bisphosphonates, which have a really interesting, because they're actually incorporated into the bone as part of their mechanism of action, that then through normal bone resorption and rebuilding of the bone, the drug gets released and can have an effect. Now, I think that's a pretty unique one. If anybody knows of any others, feel free to send me an email. But, for most medications, we really are thinking about, well, how long is the drug left in the body? But then there's a different question of how long, until those kind of benefits are gone, or how long until the risk reemerges, as well as for antihypertensives, thinking about risk of cardiovascular disease in their remaining lifespan. So I guess coming to a take-home message, for any of the clinicians on the call, I still really want to encourage you guys to consider deprescribing in older adults. As was mentioned in the introduction, another area that I'm very interested in and have done research in is consumer attitudes towards deprescribing. So of course I had to mention in this talk anyway. And myself and others have done research internationally. About half to almost all of patients and caregivers are willing to have one or more of their medications deprescribed. When we look at the average, most of these are around the 80 to 90%. And, as well as this, they do report a lot of burden from taking multiple medications. I started my career working as a pharmacist in a hospital, and the number of times I heard, I rattle when I walk, or I've got my own pharmacy at home. It really speaks to the burden on these individuals. I would recommend tapering. It's mostly the beta blockers that we're concerned about in terms of an actual adverse drug withdrawal reaction. But I think there's other reasons to do it as well. One of these is to do with that de-intensification question, and identifying the lowest effective dose that either achieves the blood pressure we're aiming for or some other target that we're looking at. And the other reason from my qualitative research is that we actually think it increases patient comfort and their engagement in the process. And I guess one of the great things about antihypertensives that we don't have with a lot of the other medications is that you can actually there's a marker, you know, blood pressure, whether it's a surrogate marker or however we consider it, there's something we can monitor when we're deprescribing. So yeah, if I can encourage anything, it's to consider it and to have that conversation with your patients. The other thing I'll mention before I'm almost done is that last year Cochrane launched a new group called the Cochrane Sustainable Healthcare. Essentially, this group is really interested in how can we reduce waste and use of low value healthcare. And they're, you know, looking at a bunch of things overall. So overdiagnosis, overuse of screening, as well as overuse of medications. And myself and my colleague, Dr. Niddick, have been very excited to be able to be chatting with these guys. So if anybody has an interest in you know, kind of almost more the methods of research and even how we do systematic reviews in this area of deprescribing, please reach out to us. No specific plans to be doing anything yet, but lots of really interesting conversations happening. So I'm just going to finish with acknowledging, firstly, the Cochrane Hypertension Group. As I kind of mentioned, it is a lot of work to do a Cochrane review, and we definitely couldn't have done it without their support. And of course, I'm up here, but really I have a number of co-authors that put in so much into this project, particularly Vanessa Jordan, who really guided all and conducted the statistics, as well as some guidance with the method. And as I mentioned, my colleague, Daniela Niddick, she and I really co-led this work. So I just want to acknowledge her as well. And I will finish there, and we'll have a bit of time for questions, I think.
Great, Emily, that was wonderful. A few comments in the chat, great presentation. Thanks for the review, very informative. And you have a wonderful presentation style, so thank you for offering such great information. I'll go through the comments and questions. First, we have one that says, could one run a large randomized control trial in some population where one could agree that there is equipoise on what to do, given that no RCTs have followed people for more than 5 years? For example, in people similar to the studies you reviewed that enrolled people in long-term care or headed in that direction, or people who are already asking, do I have to keep taking these pills, or in the frail? If we don't really know, wouldn't it be reasonable to enroll 10,000, 20,000 people internationally and follow them for 2 to 3 years?
Yeah, so I absolutely think this question really highlights what I think, you know, possibly should be one of the focuses moving forward is in those populations where we really don't know that equipoise, as the commenter mentioned, frailty. I think, you know, the falls population, people who have postural hypotension, and actually targeting this group that we think, you know, is that risk is probably a lot higher, and maybe we don't really know about the benefit, and so targeting that population, I think, would definitely be worthwhile. I've never done a multi-study 20,000 participants or something as was suggested, so I will refrain from commenting on how easy that would be to do, but you know, Optimize I think is a great example. I think they had at least a couple of 100 participants, and as I said, I think they're intending on following it up longer. So yeah, I do think that's where we should be focusing. It would be great to have studies that really did that in a robust way. The practicality and securing funding is another question, though obviously not impossible.
Sure. And a couple of related comments. One colleague of mine suggested that there are so many long-term care beds in the southwest part of British Columbia that, you know, we certainly have the population that could be enrolled. A follow-up question to the part about the study: if it were you, what would be the primary outcome, and what would you be looking for? I'm just thinking of sample size and trying to figure out what effect would you be focusing on.
I mean, I think it would depend on what population you were looking at. A really great one of, I think the really seminal RCTs in deprescribing, and many of you will be familiar with this, the study by the first author was Kuttner, which was looking at statins, discontinuation in statins in people who had a life-limiting illness. And I'm pretty sure, if I'm remembering this right, their primary outcome or one of their main measures was quality of life. And I do think, you know, if it was population targeting that end of life population, that would be personally the primary outcome, or one of the primary outcomes I would be most focused on. Although acknowledging with that, we do have a lot of limitations with the tools and ability to capture quality of life, which is I suspect why some of these studies, or particularly the early studies, didn't capture it, because the tools may not have existed at the time. If we're looking maybe at, you know, not that end of life population, but still people with moderate to high level of frailty, those in, as you mentioned, residential aged care facilities. I mean, I'd be interested in the things that really impact their quality of life. So obviously measuring quality of life, but what else impacts it? Risk of falls, postural hypertension, and yeah, any kind of adverse drug reactions or day-to-day symptoms. We know older adults underreport adverse drug reactions. They often think it's not worth the time of talking to their prescriber, or they think, oh, this is just a part of taking the medicine, or they might not think that it's a side effect. They might just think it's a part of getting older. We suspect this happens potentially with statins, which can cause some muscle pain or muscle weakness. And people don't report it because they just think it's a normal part of aging. So I guess if I could design my ideal study, it would be looking at quality of life, falls, and you know, kind of adverse drug reactions or kind of side effects they encounter on a day-to-day basis. It's obviously still going to be important to look at things like mortality, but you know, in the capturing of quality life and some of those other things, you would be capturing if, you know, for example, somebody had a stroke or another event that, you know, had a really big impact on their quality of life as well.
Very good, thank you. Someone commented that I'm all for stopping meds or not starting them in the first place, but these numbers are so small. Numbers like this would never convince me to recommend starting meds. So to be fair, the data doesn't convince me to stop them either. The patient's preference would be what would motivate me to stop them. Great work, but sure looks like we're delinquent in studying what should be a very, very large population at risk.
Yeah, absolutely.
And
yeah,
then,
no, and just to actually to address the comment, and like I really like that they highlighted, you know, I wouldn't start a medication based on this data, but actually we see, you know, older adults who are at risk being started on medications like this, or being continued on medications like this. We don't really, have any better data on continuing long-term medications like this. So I think we often see, you know, the point of action as either starting or stopping a medication. But I guess if I can encourage anything in terms of, you know, despite the limitations of this data, we need to be considering, you know, at times throughout the patient's life, you know, are the benefits still there? Have the risks changed? You know, it's not a decision, do I deprescribe or continue? I mean, it is, but seeing deprescribing as the doing something versus seeing continuation as the default, I do think we need to be considering, you know, it's not just should I deprescribe, it's okay, let's have a look at this drug. Should we continue it or should we deprescribe, and kind of put those two decisions as equal. But I absolutely agree, patients as a driver, but actually taking the time to talk to them about what their goals are, and you know, that is challenging.
No, it's so good that you say that. And one of your last slides talked about patients feeling more engaged in the process. And, you know, it's quite possible that they may have been motivated to take medications 10, 15 years ago, but their preferences have changed now that they're frail or older. And even if there's a potential clinical reason to stay on the medication or uncertainty, that may not be enough for them to still want to continue. So all sorts of reasons to talk to the patient and figure out what they want. A related comment, and I think this is meant in a constructive way, I'm not finding this information very helpful. I agree with Dr. Perry that patients want to stop meds. These small increases in blood pressure without adverse outcomes seem to support that, yet this study doesn't really let us feel confident about that, which I guess speaks to your several mentions of the uncertainty. It doesn't really answer the question you wanted to answer.
Yeah, and I guess I share in the disappointment of that person, even though we were, and as I said, kind of the spoiler was, unfortunately, this review specifically didn't necessarily give us, much confidence in being able to do that kind of stuff. But I do think we know kind of a lot of the factors to consider, not directly from randomized controlled trial, but from other stuff we know, as I mentioned, about pharmacokinetic, pharmacodynamic changes, risks associated with frailty, consideration of end of life. But yeah, I share in this as a clinician pharmacist myself. I would have loved if we'd had a bit more confidence or been able to make some clearer conclusions.
Yes. So someone is saying one challenge to address is competing patient goals. Gives a quotation: "My cardiologist told me to take these drugs until I die, but my pharmacist is concerned that I'm at a high risk of falls, which is worse, dying of a heart attack or falling, hitting my head and bleeding into the brain." So again, speaking to what's worth it for the patient.
Yeah, absolutely. And I think what also in that comment highlights that when we're talking to patients about what they value, we also need to be asking about what beliefs they have about their medications. And I, in my past life as working as a pharmacist in a hospital, and I did do some time working on a cardiology ward, and we often had people that had been relatively healthy, actually didn't take any medications before coming into hospital, would have had a cardiovascular event like an MI, and we were sending them home on 5 or more new medications. And in this particular population, we were always really concerned about, like, this is a big change. They need to take their medications. And so I'm sure I've told patients, this is a lifelong medication. You need to keep taking it, or else you'll have a heart attack, a stroke, or whatever else. And it's almost, ourselves that are helping the patients form these beliefs. I've had, in some of the focus group work we did, somebody said, oh, well, would love to stop, more of my medication, but not the statin, because I'll get a stroke if I stop the statin. So there's so much more to be learned in terms of how we communicate, and the role of, as was kind of highlighted, specialists, pharmacists, general practitioners, other specialists, nurses, other members of the care team. There is so much. It is really complex. There's a lot of research in that area, and hopefully we will kind of have some more tools and ways that we can address those beliefs that have been developed.
Sure. And one comment about is lowering the dose to the lowest effective dose an option that's included in deprescribing? And I think you said that was part of your protocol, that dose reduction was also considered. So we did include, if we'd found a study that literally continued one group on the same drug and dose reduced in the other group. We didn't find any studies like that. In a different review I've done, same thing. There aren't really many dose equivalent studies in terms of decreasing the dose. So we were looking at that. But I think it definitely speaks a lot of the time, when we're talking about blood pressure targets or risk, looking at what blood pressure they're on. And then it's also the question of multiple antihypertensives. So definitely reducing the dose, monitoring how they go, looking at which drugs they're on, which ones are most important, and things like that. Great. Thanks, Emily. It is 8:01. So just a quick reminder to people that we'll be sending you an evaluation form. We'd be very happy if you completed that. If you do and send it in, we promise to send you a continuing education certificate. And to finish, I would like to thank you so much, Emily, for a wonderful presentation, very informative. Thank you for answering all the questions. It's been a pleasure spending the evening with you, and thanks to all the people that signed in, and hope all of you have a good evening.
Thanks again for the invitation, and thanks everyone for listening.
Have a good evening, everyone. Bye for now.